Hello friends, a very good morning. At the onset, I wish to express my gratitude to Health Equity Research Initiative team based at Achutha Menon Centre for Health Science Studies, Trivandrum, for inviting me to be part of this dialogue for health equity, Equilogues. I'm particularly thankful to Professor T. Sudri Ravindran for giving me this opportunity. Today, I'm going to share some of my ideas with you on health and well-being. How does this has to be seen in terms of gaps that exist between gender as an identity and social identity vis-a-vis caste. I will try and analyze the connect between what are the issues which come to become important in terms of understanding social identity on one hand and gender on the other hand. As it is evident from the first slide, when we want to understand vulnerabilities, there can be of different kinds, of different nature. One is where an individual becomes vulnerable due to certain criteria, and on the other hand, it's groups that become vulnerable. And their factors could be ranging from individual level inabilities to inabilities which are imposed based on the group membership. And therefore, it becomes very important to try and understand what are the dimensions of intersectionality, therefore, which cut across one's social identity vis-a-vis identity in terms of gender or in terms of connect with a region or religion. I would want to emphasize how do vulnerabilities become important. There could be vulnerabilities experienced in a particular physical space, in particular form, or because of certain agencies. So what's important is to understand where are these vulnerabilities experienced, how are they experienced, and what are the causing agents of these vulnerabilities. And that perhaps allows us to talk about social exclusion and discrimination, which acts as a barrier to accessing any kind of resource, particularly the health resource. The next slide, therefore, allows me to talk about what is the context of marginalized groups in India. Caste, like I said, is a unique feature when it comes to India as an entity, as a physical entity. Caste, as we all know, is something which is related to structural exclusion, which has certain embeddedness when it comes to inequality, which gets generated on the basis of certain kind of social hierarchy, based on which some groups are denied access to certain resources such as economic opportunities for employment, education, civic and religious rights, and therefore there are certain contexts that makes these people socially and physically isolated. They remain without any kind of assets, they remain without any form or levels of educational attainment, and of course without civil rights. Contrasting caste as a group vis-a-vis other social groups which we often use in our administrative context, the other backward classes, for example, who have remained educationally and economically deprived at certain levels, in certain contexts, but certainly they do not suffer any kind of untouchability and therefore social and physical isolation. Tribal communities and also groups which are identified on the basis of ethnicity have certain context of physical and social separation. But this isolation certainly is not structural. Similarly, if we look at women, the gender-based identification of individual, it is important to understand that there are inequalities when it comes to any kind of development indicators we want to make consider it vis-a-vis men, or the difference between men and women. We would want to acknowledge that on one hand there is a disparity between men and women, and on the other hand there is a disparity across social groups. So it also then puts women who belong to the scheduled communities, Dalit for instance, or as another nomenclature, are the women who suffer from multiple disadvantages based on gender, age, language, religion, particularly in terms of if you look at certain practices like Devadasi, for example. So the connect is that when it comes to Dalit women, there are multiple disadvantages that they have to experience. As I move to the next slide, in order to share some of the ideas where the nature of group inequalities gets located, these group inequalities are largely based on ownership of assets, dependence on employment, the wages that are accrued vis-a-vis employment, differences in literacy, and of course the civic amenities. Civil rights also allow us to look at the caste-based discrimination, especially in context of the atrocities which are experienced by individuals who are at the lower rung of this caste hierarchy. If we look at any of the data which talks about or allows us to think about development, we will be able to understand that there is disparity across social groups based on any of these indicators. Therefore, I think it becomes extremely important for us to consider how these inequalities become important in aggravating deprivation, in aggravating poverty and vulnerabilities, as is evident in the next slide. Although we see the upward trends in the growth rate in India in the recent decades, however, the decline in poverty and infant mortality, although visible, there are improvements in indicators such as life expectancy and educational attainment. These achievements, however, have continued to coexist persistently along with the high levels of poverty. There are low levels of education, low levels of skill and productivity for a mass majority of workers. There are low nutritional status, particularly that of children. And there are, of course, intergroup and interclass inequalities. Therefore, if I share through the next slide the data on poverty ratio among the social group which the Planning Commission gives us, it's very interesting to see that while there are changes in terms of the upward changes which are visible across the social groups, what is very important is to see the rate of change which is different when it comes to the Dalit communities versus the non-Dalit communities. And that's the pointer I think it becomes important for us to consider important, because if we look at for instance 62% which is labeled as the poverty ratio among the scheduled communities, scheduled caste in 1994, it diminishes to about 54%, while if we look at the data on all the groups particularly, or if you look at the others particularly, it declines from 27.1% to about 15.5% or so. So the idea is that change perhaps is although visible as larger among the scheduled caste group as compared to the non-scheduled caste, the high caste groups, also because they already existed at a higher level of poverty, the low level of poverty as compared to the ones which were in the almost half of the SC population, which was listed at the level of poverty in 2004-5, for instance. Similarly, if we look at the disaggregated figures for urban populations, similar scenario is visible even across the social groups in the urban areas. The pointer which is evident from the next slide, which looks at caste and wealth inequality in India, while there are instances of reduced poverty, while there are instances that there have been upward movement vis-a-vis these indicators among the social groups, what is important for us to recognize that the upward change for the SCs and the STs is slower or sluggish as compared to those who do not belong to these communities. That's precisely is also evident when we look at the trends in literacy in the next slide. Across the social groups from 1961 to 2011, we do see the gap narrowing as we move to 2011. Similar is this scenario when we make a comparison across the religious communities. And it is also reflected in the next slide, which is talking about socioeconomic differentials by social group in present times. What's important for us to note that if we look at the differential between men and women across social groups vis-a-vis the educational attainment, men and women who have remained without education, we see that it's the Dalit women who have the highest, who are the worst hit when it comes to remaining without education. And it's equally corroborated in the next slide when we talk in terms of the child and infant mortality. We will not be surprised to notice that these indicators are very, very poor, reflecting very poor scenario when it comes to the scheduled caste and the scheduled tribe as compared to the high caste populations that is listed, that is identified through this NFHS survey. Similar is the scenario when we look at the safe deliveries, particularly if we look at, if we try and understand the disparity across place of residence. If we look at across religion, particularly two major religions, we see the vulnerability rests in rural areas. It rests in the one particular largest minority population, religious minority population. We have the tribal groups which are worst hit as compared to the poor. In fact, the scheduled tribe have, as compared to the scheduled caste, they are worst hit as compared to even the lowest quintile population. They are the only less than a quarter of those in the lowest wealth quintile are covered with safe deliveries. Similarly, we can say that the scheduled castes are better served in terms of the coverage of safe deliveries as compared to the scheduled tribes, and regional problems in accessing the area could be one of the reasons for this. We can also make similar pointers. We can get similar pointers when we look at what are the problems which women face in terms of the social gaps, in terms of how when they try to access the healthcare. It's fairly well evident that issues like where do they get the money for treatment, what happens when there are no providers available, the distance becomes important, and we see that the scheduled communities are fairly worst of course the worst is the scheduled tribe, followed by the scheduled caste communities. So what is it that becomes as the barrier to access these services? And in the next slide, I do wish to share this, that when we talk in terms of certain barriers, and it comes from some of the data which has been gathered through the field-based investigations, there are refusal to observe certain norms which are mandatory in caregiving but are very often violated. Often they are manifested in the form of refusal to touch the person who is seeking care, to enter the houses where caregiving is to be done, or to share perhaps the seating areas along with others. even objecting to the location of the seating arrangement, sharing food and water, and even transportation. Some of these pointers tell us that there are certain very specific identified spheres in which such kind of behavior is visible. These spheres, as evident in this next slide, allow us to talk about the discrimination which is likely to be faced at the care delivery centers when the care is delivered at home, source of water supply, and also the role in the local self-governing bodies, individuals who have important roles in local self-governing bodies, and also programs such as ICDS and health camps, which matter when it comes to experiencing some kind of discrimination which could be meted out to individuals who are seeking care. Therefore, creation of differential awareness among users, which is where some groups can be informed well enough about what are the services being provided as compared to others, becomes relevant in understanding why the access differentials to the resources of health are visible, are evident. Some data which I would want to share in terms of the time spent by the providers, or the time spent between the healthcare seeker and the providers, based on one of my studies done in the western part of the country, as is evident in the next slide. If we look at the reported time spent by women, the women are reporting that this is the time which we have spent with the provider for various spheres, for instance, diagnostics or visit to the doctor, for counseling, for taking the medicines, for pathological tests, or seeking referral. So we see in this, what is evident from the study, that when it comes to the Dalit women, there is lesser time spent in terms of these different spheres, about 5 to 10 minutes during a visit, as compared to 5 to 15 minutes when a non-Dalit woman is using. Dispensing of medicine also, it's about 2 to 4 minutes on an average, as compared to 4 to 8 minutes. So the time which could have been a little longer in terms of understanding what the issue could be for a Dalit women is comparatively lesser than the non-Dalit women. Similarly, we see the situation is in terms of different forms which are visible in terms of practicing discrimination. For example, about 49% women reported that the time spent was lesser. Less time was spent with them, between them and the doctor, as compared to non-Dalit women, which is about 15%. What is also important to note here is that whether it's Dalit women and men or non-Dalit women and men, women seem to be at a disadvantaged position as compared to men. But Dalit women seem to be the most disadvantaged across men and women and Dalit, non-Dalit identities. Some illustrations, if I can quote from the same study as is evident in the next slide. Place of discrimination when it is at home, most of the time it has been reported that if a provider is from a different caste group than that of the user, the interaction across the limits of the housing unit happens in a very strange way. Often the provider does not enter the house of the user, but if the communities are same for the provider and the user, this interaction is fairly well happening across by visiting inside the house, etc. Another important aspect is when the providers, such as doctors or pharmacists or lab technicians or the grassroots level workers like A&M and ASHA, it's important to note that many a times, as reported earlier, during the diagnosis, doctors are likely to spend less time when it is the Dalit women. Dispensing of medicine has been noticed to be done by not putting the medicine in the hands of the women. There is often the reporting that there is use of improper words by the providers such as lab technicians. And also, many a times, these visitors do not happen to go to the houses where they should be going and delivering information. So we can actually see that the nature of discrimination is fairly evident in terms of not entering the house. This is in the next slide. They continue to remain in the outer courtyard. They have separate bowls and pots and utensils if they offer to consume certain eats, and they have to, if the provider happens to be of a Dalit community, they're supposed to wash the utensil after they have used it. And something which is very important is that their efficiency as a provider is always doubted. So as provider, they have to face a number of problems in terms of being able to render out their services. Very often the provisioning of services happens from the central part of the locality. And most often the center part of the locality, particularly in the village scenario, is often not accessible to the Dalit communities. So when the provisioning is happening, it doesn't really spill over to the Dalits also, because they are fairly in the outskirts, and therefore reaching up to the central part becomes often restricted in many ways. So that's one issue which perhaps becomes important for us to take note of. And also when these providers are interacting, there are evidences that there's an element of demeaning words being used. There's avoidance of touch being done over there. But there's also evidence if the providers have been sensitive, the provisioning of the care has been reaching to the women who belong to the scheduled communities. In fact, Dalit providers are fairly well acknowledged in terms of provisioning by Dalit users, unlike when the religions are different, the groups are different for the two users and the providers. Well, then if we look at this in terms of what are the health concerns, and especially in the context of universal access to health care, as I'm sharing in the next slide, some very important context is that public health places in its core the context of safe drinking water, sanitation and drainage, hygiene and housing. But when you look at some of these indicators that I've talked about, there are fairly evident discrepancies and disparities across social groups when it comes to each of these elements. And therefore, such nature of deprivation and denial to access for different resources becomes evident in terms of the social identities, and it also then connects to the healthcare resources. Now, if we go ahead with this in terms of contextualizing how the social development goals and health particularly gets interlinked, we see very well that the three contexts of the social indicators, the environmental indicators and the economic indicators intersect in ways through which there necessarily have to be the context of making these three connects equitable, livable and viable. Then only perhaps this whole idea of making sustainable development address the context of health becomes relevant. Also because one of the core context of the sustainable development goals as it moves ahead from Millennium Development Goal is to ensure dignity of the people, prosperity, talk about human access to various kinds of resources, the environment, justice context, and of course the partnership. And for all the 17 goals that have been listed for Sustainable Development Goal, almost all of them connect with the context of health, be it poverty or reducing inequality or environment and climate change. Any of the goals have a very strong connect with health. And therefore, when we contextualize the status of Dalit women, and then see how best or worst is her condition, it's very evident that if we go by the data, as is evident in the next slide, Dalit women constitute almost half of India's 116 million Dalits. And they comprise about 16% of India's total female population, about 8% of the total population. And despite of all this, there is isolation on the axis of economics, religious, political and ideological context. And therefore, I think it was important that in 2017, the report of the UN Committee for Elimination of Discrimination Against Women addressed the issue of Dalit women in India. It is important, therefore, to contextualize and understand what is the position of Dalit women in the larger frame of the social arena in which women are located. Most of the time what happens is that in general, women do not report violence. Only 1% of the cases that are actually filed and end in convictions. If you look at the 2009 report at the UN Special Rapporteur of Violence Against Women, it accounts that Dalit women in India are being raped and beaten by high caste in the course of their daily lives, such as while working in the fields, going to the market, or going for domestic work. And therefore, if we look at, as is evident in the news slide, media perception of violence and health outcome, there's plenty of money and media coverage for campaigns for urban educated girls who face violence at workplace. But we don't really come to hear much on what's happening in the caste-based atrocities when it is done on the Dalit women. Both kinds of violence are lumped together, in fact, as one broad category of violence against women. Although violence when faced by middle-class women is not really very articulately comparable with the levels and scales of structural violence that rural Dalit women face. And therefore, it may not be incorrect when we try to assess that women and girls in urban areas, although are more assertive to demand and access health care, an urban structure is also more likely to have be better equipped in terms of health facilities as compared to rural women. The access also becomes poorer for women and girls in the rural areas. Therefore, to cite a kind of an example in the next slide, way back in 2009, there were 2 schoolgirls who died due to what happened in the school. One of the girls was suffering from asthma, a student of an upper caste institution who died. She had received some basic treatment and was also taken to the hospital. Another girl, a little slum girl who died quietly at home after being punished by her teacher to stand in the sun, crouched in the half-sitting position. Media covered in a frenzied mode everything of girl A, while there was almost total silence on the other. Girl B was a Dalit, poor and thus not worthy of media attention. This is what I quote from Cynthia Stephens' work of 2009. And therefore, in the next slide, I argue that what is important is how the perception of Dalit women actually which happens as Dalit women is something which is outside the larger whole. It's the other. And this leads to the exclusion and invisibility, and some kind of structural violence which is experienced by Dalit women gets also accentuated in some sense. Thus, even among women, she is perceived as others. She, therefore, is at the end of the long social ladder, manifested in many ways through her condition in total social, physical, economic, and political vulnerability, evident in the struggle for the basic needs such as food or water, in the submission to sexual violence for the sake of employment. So Dalit women's burden is doubled, tripled and quadrupled. Very often it is evident that women academicians and the forerunners of gender cause consider women as one homogeneous group. But it's only when we disaggregate this group we realize that at the most disparities are superfluously addressed by many in terms of social hierarchies. Very slight similarities which can be drawn in terms of discrimination and exclusion from access to resources and services between women and Dalits is more likely than not to cause a furor among particularly the women academicians. But it's important to note that both women and Dalits suffer from subordination. Both show poor social development indicators. Both are considered impure and unclean. Both have been excluded from decision-making processes one or the other level. Both have restrictions in expressing their voices. Thus, Dalit women her experience of denial and deprivation are multiple. If we look at this context vis-a-vis the Sustainable Development Goal, as I move on to the next slide, after the Millennium Development Goals of 2015, which the emphasis has been very clear now that ending poverty and hunger, ensuring gender equality, empowering women and girls, reducing inequality within and also among the countries through a couple of specific goals. Goal 3 ensures that there would be healthy lives and well-being for all. Then there is Goal 4, which ensures inclusive and equitable quality education and promote lifelong learning opportunities so that inequalities could be removed as is embedded in Goal 10. So what's important is also therefore to connect how best do these goals are in a position to be able to talk about what their aims are. One reference I am quite tempted to make at this point is that of the idea of Dr. B.R. Ambedkar when it comes to women's health. He propounded that social protection promotes dynamic, cohesive, stable societies through increased equity and security. And it was through his efforts that maternity benefits were given to women based on the experiences of the workers in the mica mine as part of the Labour Welfare Fund Bill. Way back in 1927, as the chairman of Satyagraha Committee of Dalit Movement, he addressed a gathering of Dalits who were fighting for their right to equality to have safe drinking water. This was in Maharashtra. He was addressing the Mahars in the Chawdar tank in Mahad Taluka. To me, I would want to very emphatically say that this was in fact the initiation of the right to have safe drinking water in order to ensure good health. I would wish to continue this in this next slide to say that by doing this, by bringing women in the core of his argument, he was also perhaps trying to put across the idea that it's important to contextualize the centrality of women in any kind of development initiative, educating women, intercaste marriages, interdining as methods of patriarchy will superimpose themselves and allow to bring in the kind of parity which is envisaged by most governments. In fact, he did say very categorically and believed in it very emphatically that progress of a community could be best measured by the degree of progress which women have achieved. Education was the only means by which he said women can overcome oppression and move towards democratic participation and involvement. And he very, very strongly established his conviction for gender equality and therefore put very strongly across his efforts in terms of guaranteeing educational opportunities to women in women in India. And very, very neatly, his ideas on women's health were evident in the Bombay Legislative Council discussion on 10th November 1938, in which disability of the parents was acknowledged as the prime reason for impacting on children physically, mentally, and also financially. And that also therefore puts us to consider him as one of the forerunners who saw the reproductive rights of women as important for their development. He proposed limiting the number of births for the health of the women and the children instead of the conventional stand which was for controlling population. So what was important is to be able to recognize the sensitivity towards gender embedded in social identity. And therefore, I think it's important to revisit the way infrastructure exists for healthcare today. How do we build in that kind of sensitivity which intersects vis-a-vis identity that is social, vis-a-vis identity that is based on gender? How best can educational resources, how best can availability of safe water and sanitation need be prioritized? How best can be the implementation of national health programs be made accessible to women of all social identities, irrespective of any kind of hindrances which some women face versus some women who do not face those kind of hindrances? And therefore, this becomes extremely important to be able to talk about in terms of how best the inclusion at all levels of each of these stakeholders can happen vis-a-vis women across different social groups, vis-a-vis men across different social groups. Thank you very much.